Good day, dear students. Today we will speak about diseases of the tongue and lips in children of different ages and about cheilitis and treatment, diagnosis and etiology of these diseases. First of all, I want to speak about the structure of the mucous membrane of the lips. First layer, it is multi-layer with non-keratizing epithelium. The second layer, it is on lamina of the mucous membrane. Next one, it is submucous membrane. Fourth, it is a mixed salivary labial glands. And the last one, it is excretory ducts of the labial glands. 5 layers. Features of the structure of lip tissues in children, newborns and infant. So basement membrane thin, delicate, yes, and mucous membrane of lip contains a significant amount of acidic mucopolysaccharides, which provides a high regeneration capacity. In children from 1 to 3 years old, the epithelium of lips and cheeks has high permeability and contains a little glycogen, which provides an acute and diffuse course of the pathological process. Next one is basement membrane is thin, and collagen and elastic fibers of the own layer of the mucous membrane are loose, non-oriented, and have a delicate and thin structure. The proper layer of the mucous membrane contains a large number of cellular elements. And in children from 4 to 12 years old, the number of blood vessels and cellular elements decreases. The mucous membrane permeability decreases, and the development or sensitization and allergization of the body are created. Cheilitis. It is a group of inflammatory diffuse diseases of the tissue of the lips, red border, mucous membrane, and skin. And you should know about classification. It is international classification of disease. Diseases of the lips. First of all, it is angular cheilitis, angular cheilitis, and lip adhesion crack. Next one is cheilitis glandular apostomatous, cheilitis exfoliative, cheilitis, and hyalodynia are the specific diseases of the lips, and diseases of lips unspecific. And the last one is bite in the cheek and lips, so mechanical injury. And clinical classification of cheilitis, you should know about independent. Cheilitis is exfoliative, meteorological, glandular, microbial, fungal, contact allergic cheilitis, and traumatic. And symptomatic or secondary group of cheilitis, which are consequence of any disease. It is atopic, eczematosus, hypovitaminosis cheilitis, chronic lip fissure, and macrocheilitis. So you should know that cheilitis is an inflammatory process of red border, mucous, and skin of lips. And clinical forms of cheilitis are determined by the inflammatory process, character, morphology, and functional features of oral mucosa, labial red border, and skin in children. Independent cheilitis. Next one, it is classification of also by etiological factor, so associated with local etiological factors and with general changes in the body or occurring with somatic diseases, and unclear etiology. Next one, this according to the clinical course, it can be sharp or chronic. By localization, skin manifestations, then changes in the corners of the mouth, changes in the red border or a clean zone, and changes in the mucous membrane of the lips, and combined lesions. By pathomorphological changes with the formation of primary elements, so inflammation, spot, nodule, node, tubercle, bladder, abscess, blister. With the formation of secondary elements, it is erosion, after, ulcer, crack, scar, flake, crust, lichenization, etc. So, exfoliative cheilitis. It is chronic disease in which only the red body of the lips is affected. And etiology that you should know, it is a violation of the architectonics of the lips, their correct closure. Then neurogenic disorders, hypervitaminosis of ascorbine, nicotinic acid, and vitamins of group B. Next one, dysfunction of the thyroid glands and central nervous system, genetic factors and immunoallergic factors. And forms that you should know can be dry and exudative. It is exfoliative cheilitis. Next one. This disease characterized by a desquamation of the red border of lip more often and lower lip. In most cases, the disease has a chronic course. And etiology, we speak about etiology. So, clinics, dry form. A dry and an exudative form of chronic exfoliative cheilitis are distinguished. The dry form is characterized by formation of gray or grayish-brown scales of the red border of lips. The scales peel easily, leaving no defects on the adjacent mucosa. In case of exudative form of cheilitis, a layer of dense, grayish-yellow or brown crusts appears of the red lips border closer to the mouth angles. After the crusts are removed, a bright red smooth surface is exposed. No erosions are observed here. The lips are enlarged in size, painful at touching. Localization from the cleanse line to the middle of the red border of the lips is typical for this kind of cheilitis. In case of the dry form of the disease, children complain of the lip dryness and scales. The exudative form is accompanied by sensation of burning, pain, and tension of the lip, their swelling. So, in the case of the hypervitaminosis conditioned cheilitis, children can have a scaling skin on the face behind ears and then seborrheic dermatitis. So, exfoliative cheilitis should be differentiated from meteorological contact and allergic cheilitis. So treatment should begin with elimination of oral breathing and disorders in labial architectonics treatment and different exercises children should do. Topically, application with natural oils and vitamin containing medications. So, for example, keratolinum, dark rose oil, retinol, carafillan ointment, calendula cream, and spermaceti cream. So, differential diagnosis, dry form of actinic cheilitis, and we should doing a differential diagnosis with meteorological cheilitis and contact allergic cheilitis. Exudative form with cheilitis manganoti, atopic cheilitis, erosive and ulcerative form of lupus erythematose, and lichen planus. So, and treatment elimination of violations. I speak about this in previous slide, and locally different application with keratoplastics. And removal of scales with 0% solution of proteolytic enzymes, for example, trypsin and chymotrypsin. In the exudative form, you should use boric or boron vaseline ointment, laser therapy, application of glycocorticoids in the short course, ultrasound administration of hormonal agent, radiation therapy in combination with corticosteroid ointments, and sedatives and antidepressants. Next one, it is contact allergic cheilitis, is a manifestation of an allergic reaction of type 4 and complaints. So, complaints, it is itching, dryness, burning, swelling, and redness of the lips. And on contact with an allergen, the formation of erythema and flaking. With pronounced inflammatory phenomenon, it is small bubbles after opening which erosion and cracks are formed. And localization, it is red border of lips. Differential diagnosis you should doing with a dry form of exfoliative cheilitis, then meteorological cheilitis, and atopic cheilitis. And this form of cheilitis is a classical manifestation of an allergic reaction. And etiology factors, it is more often observed in children at school age and develops as a result of labial mucous contact with various chemicals. In children of school age, it can result from a bad habit to keep various subjects in the mouth, and this form of cheilitis may also occur after the use of elixirs, some toothpaste, etc. Then absorptive ability of oral mucosa is very high, and those allergens quickly penetrate into the mucosa after contacting it. And clinics, an erythema appears in place of contact with an allergen, and some scales are observed. The process localizes on the red border of lip and on the skin. In some patients, an expressed inflammatory reaction is observed. Small vesicles appear of the inflammatory background, and in some times they burst. Patient complains of itching, dryness, and burning sensation in lips. And treatment. Treatment involves the removal of contact with allergen and prescribing of desensitizing drugs. And local anti-inflammatory treatment is indicated, for example, sodium methanominum solution, just 1%, and salicylic acid solution, 1% also. Then smearing of lips with anesthesium and glycerol from 1 to 10 procedures. And if non-specific anti-inflammatory treatment proves ineffective, then ointments with corticosteroids should be prescribed for 4 to 6 days. Next one, meteorological cheilitis or actinic cheilitis. So disease is characterized by a chronic inflammation of the red border of the lips, and which occurs under the influence of meteorological factors, for example, cold, wind, solar radiation, humidity, or dusty air. And of course, it can be bad habits, for example, lip biting, leaking, and contribute to the disease development. And clinics, so complaints, it is feeling of tightness, dry lips, then congestive hyperemia and infiltration of lip tissues, and usually it is lower lip, chronic course, and connection with an etiological factor. And clinics, hyperemia or infiltration of lip, more one, often lower lip, are observed. The lip surface is dry, it can be covered with scales. Skin and mucosa of lips are unchanged. And children admit sensation of tension, dryness, and burning of lips. And diagnostic, so we should know all about anamnesis data. It is very important, and meteorological cheilitis should be differentiated from the contact allergic cheilitis and a dry form of exfoliative cheilitis. And treatment, first of all, the factors causing cheilitis should be eliminated, and light protective creams and ointments are prescribed. In case of the significant inflammatory reactions, we should use prednisolone ointment for a short-term course. And glandular cheilitis, a disease that occurs against the background of congenital hyperplasia and hyperfunction of the small salivary glands and their heterotrophy in the Klein zone. And you should know about congenital, the small salivary glands, and it is etiological factors, violation of lip architectonics, bad habits, biting, and chronic lip trauma. And next one, it is bad habits. Yes, and psychogenic factor and genetic predisposition. It is glandular cheilitis. And this form of cheilitis is characterized by a chronic inflammation of small salivary glands of lips. So, clinics, more often the disease occurs in the puberty age. Patient complains of pain, of drying, swollen and flaking lips, cracks, erosions and macerations. The objective examination reveals broadened excretory ducts of the small salivary glands and hypermose mucosa of lips. If the illness lasts for a long period, the lips increase in volume. Under pressure, the lip glands excrete drops of transparent or turbid liquid. It is dew drop symptom. The red border of lip is covered with scales. Often fissures and erosions appears at this background, and diagnostic is not complicated. So complex treatment is required. So look please to clinical cases. It is due symptom. Yes, this secretion after drying for 20 or 30 seconds. From them, dilated ducts of small salivary glands in clean zone. And treatment, you should know about is that complex treatment is required, and topical ointments with antibiotics and corticosteroids should be prescribed. In case of a steady progress, Bachelor radiation therapy and electric coagulation of salivary glands are indicated. The general treatment should include antibiotic therapy and prescription of sulfanilamines and general radiation or ultraviolet radiation. So here you should here you can see local treatment and first stage anti-inflammatory therapy, then sanitation of the oral cavity, oral hygiene of course, rational prosthetics, then elimination of bad habits, treatment of the underlying diseases and elimination of course, application with enzymes, and irrigation of lips with aerosols. And second stage, it is diathermal coagulation of hypertrophied glands or their surgical excisions, and border race of Butcher and clinical examination. Microbial cheilitis, so etiology, it is streptococcal infection, and candida, sorry, here is mistake, and predisposing factors, decreased muscle tone of the orbicular oris, and violation of lip architectonics, bad habits, deep bite, decrease in the body immunological reactivity. And children of all ages can get the disease, but preschool children get it more often. So clinical picture, children complains of pain and bleeding cracks, then in the mouth angles, and swelling of lips and scales. Depending on the microflora which causes the disease, it is chronic streptococcal and mycotic cheilitis. So the objective examination of the mouth angles detect hyperemia, swelling, and fissure of varying depths. Affection of the adjacent areas of skin to the mouth angles is typical for this form of cheilitis. The skin is hyperemic. It contains scales and varying size. In case of a long-term progress, the red border of the lips becomes thick and swollen and scaly. In weak children, so on the background of hypervitaminosis after recent infection or other diseases, a streptococcal impetigo is diagnosed. So the disease is contagious. In case of join of the secondary staphylococcal infection, a vulgular impetigo develops. And what about diagnostics? Sorry. So for diagnostic bacteriological examination of material from affected areas should be performed in these cases, and treatment depends on the result of bacteriological analysis and antibacterial treatment, of course. And antibacterial treatment in these cases is combined with the oral cavity sanation and general hygiene observation. Antibiotics are prescribed. An ointment and cream of gentamicin sulfate and ointments, for example, streptocid, furosemide, rivanol, and zinc oxide. For treatment of pyoderma, purulent processes in the facial and labial skin, the use of 2% water and alcohol solutions of tetraethyl diamine 3-phenyl carbohydrate sulfate is recommended in these cases. And traumatic cheilitis, so etiology, it is acute and chronic trauma with NLG syndrome. And clinical page, it is general condition of the child is not disturbed. At the site of injury to the mucous membrane, the surface is uneven. Fragments of vial epithelium are visible, sometimes small hemorrhages, and erosion of regular shape. Decubital ulcer is usually solitary mucous membrane and swollen around here, and moderately or severely painful. Atopic cheilitis, it is disease is a symptom of atopic dermatitis and has a chronic recurrent course. So etiology factors determine their predilection of atopic allergies promote the development of atopic cheilitis. The disease can accompany the bronchial asthma or allergic rhinitis. Elementary disorders play an important role in pathogenesis of neurodermatic in young children. And you should know about predisposition of to atopical allergy and elementary disorders. And histological reaction, we should know anamnesis data, and exacerbation in the autumn winter period. In the summer you can see remission. After 18 years, self-healing is possible. Predisposing factors and pathological changes in the epithelium, acanthosis or perikeratosis in connective tissues. And clinica, an erythema with distinct borders and edema appears on the red lip border and in the adjacent skin and in the mouth angles. The area can be contain crust and excoriations. After fading of the acute inflammatory process, lichenization of lips is observed. It is characterized by a thickening skin, its enhanced pattern, and a disturbed pigmentation. The red border of the lips is infiltrated, the lip can increase in size, and its pattern is enhanced. Small radial growths of the red border in lips and skin scales are typical for the disease. In the mouth angles, infiltration, fissure, skin dryness, and scaling. The skin on cheeks, forehead, elbow, and popliteal folds is affected in most cases. The skin is dry, hyperemic, lichenified. It contains many excoriation and crusts. Intense itching is accompanied by exudative manifestation in the form of edema and weeping lesions. And treatment. What about treatment? Should combine general and local therapy? A non-specific desensitization treatment with antihistamine drugs and vitamins is indicated. And ointment with corticosteroids 2-3 times per day, and antibacterial and anti-inflammatory drugs are applied topically. So, in case of significant infiltration and localization, ointment contains from 3 to 10% of naphthalene and sulfur are recommended. Is advisable to avoid consumption of carbohydrates and spicy food. For prevention of cheilitis, relapses, a long-term stay in the south region is recommended for the child. Eczematous cheilitis, so it is symptom of seborrheic eczema, and etiology can be microbial, food, chemical, drug allergens. And predisposing factors, please look into these pathological changes in organs and system leading to formation of eczema and allergens, and violation of lips. Clinics, it is acute eczematous cheilitis, hyperemia, edema of the lips with a spread of pathological changes in the skin, erythema, vesicles that become wet, merge, forming ring-shaped scales and crust, and polymorphisms of lesion elements. And chronic eczematous cheilitis, red border and tight lip skin due to inflammatory infiltration. And we can see nodules, vesicles, crusts on the red border, and painful cracks, crusts, and dry peeling. Look please this eczematous cheilitis and clinical pages. Treatment, of course, you should treat this disease together with pediatrician and allergist. And we need to prescribe a non-specific hypersensitizing therapy and vitamins. Of course, diet, and for severe forms, corticosteroids. And locally, for acute or exacerbation, steroid-based ointments. After reducing hyperemia and edema, sulfur ointment and naphthalene. Of course, keratoplastics and oral cavity sanitations. Macrohelitis, it is Merkerson-Rosalima-Rosenthal syndrome. Etiology, infectious and allergic origin, foci and fossil infections. Then congenital malformation of the lymphatic vessels, and vasomotor disorders in neurodystrophic processes. So, violation of microcircular blood and limbs, it is pathogenesis of this disease. And clinic, first it is symptom, sharp start, early signs, pain like facial neuralgia, macrochilia, edema and hyperemia of the skin of the lips and underlying tissues. Palpation of the lips, the consistency is dense, elastic, without infiltrations. When pressed, no depression, and the formation of scales and crusts. Symptom 2, it is unilateral paralysis of the facial nerve. And third system, it is folded tongue, observed in 80-85% of patients, and often there are foci of epithelial desquamation of the tongue. And it is macrocheilitis. Treatment. General and locally. General treatment, corticosteroids, broad spectrum antibiotics, antihistamines, and vitamins of group C, B, and PP. Locally, it is electrophoresis with heparin and lipase mount and paraffin therapy, and contrast temperature method application with heparin and dimexid. Physiotherapy, it is burnout currents, ultrasound, and helium neon laser. Control of the nature of closing lips, breathing, and myotherapy and lip massage. And different courses. Chronic lip crack, vertically located defect of the red border of the lip, resulting from the loss of its elasticity. Etiology: poor oral hygiene, bad habits, chronic trauma, meteorological factors, and hypervitaminosis of group B and A. And of course, microbial flora. Line cracks predominantly in the middle part of the lips and can pass to the lip of the lips, can bleed, the skin is not affected. And treatment, of course, elimination of the causes and bad habits. And locally, it is ointment containing corticosteroids, it is physiotherapy, crusts and scales are softened with warm solutions of proteolytic enzymes. And in the absence of the effect from the treatment, it is necessary to carry out surgical excisions of the crack within healthy tissue. Next one, it is diseases of tongue, glossitis, and geographic tongue, medium rhomboid glossitis, hypertrophy of the papilla of the tongue, atrophy of papilla of the tongue, then folded tongue, and glossodynia. And next one, classification of glossitis. So you should know about traumatic glossitis, infectious diseases of the tongue, glossitis in pathology is pathology of organs and system. Then neurogenic diseases of the tongue, tumors of the tongue, drug-induced glossitis, and first of all, it is discriminative glossitis or geographic tongue. Sorry, guys, here we have mistakes. I'm sorry. So, discriminative glossitis is often observed in both children and adults. Chronic diseases of stomach and intestines. So, helminthasis, exudative diathesis can be probable cause of trophic disorders in the epithelial layer of the dorsum of the tongue in children, and in a number of cases, no contaminant diseases can be defined. And clinically, the lesions of the tongue are accompanied by relapsing local disorders of keratinization process and dystrophic changes of filiform papilla. And red, you can see red spot areas, losing several epithelial layers, and periodically appears on the tip and the dorsum of the tongue as a result of epithelial sloughing. And the spots expand irregularly and progressively. They occupy new areas. And several desquamation areas of oral or circle shapes overlap, forming a bizarre picture. Then the general condition of the child is practically unchanged. So there is, you should know about that we don't know non-specific treatment for desquamative glossitis, and children with this illness need orally cavity sanation, and local irritants have to be avoided. In case of pain and paresthesia, it is recommended to apply citral solution, and 10% anesthesium suspension is vegetable oil. It is advisable to conduct the child's examination followed by treatment of systemic diseases in cooperation with a pediatrician, of course. Then rhomboid glossitis and etiology violation of embryogenesis. So, of course, rhomboid glossitis is a variety of desquamated glossitis. The disease is characterized by an area of epithelial desquamation in the middle line of the tongue and closer to its root. The area is bright red, often with a fishy surface, which is unchanged for a long time. The disease is quite rare in children, and rhomboid glossitis is possibly connected with disorders of the secretory function of the digestive tract and congenital tuberculosis or syphilis. It is assumed that desquamation at the root of the tongue is caused by embryonic development disorders. The disease is chronic. The clinical picture can be unchanged for years, so non-specific treatment is required in this disease. And then, black hairy tongue may occur in children as a result of distorted psychological process of desquamation of the corneal epithelial layer in the filiform papilla of tongue. The symptom is characterized by hyperplasia of papilla resulting in their significant lengthening, so more than 1 centimeter. Food dyes color, a thick layer of coating in the dark, and sometimes even black. The anamnesis, as a rule, contains diseases of the stomach and the intestines with an upset secretory function. And prolonged antibiotic treatment lowered appetite and dyspeptic problems. Children complains about bad breath. Concomitant candidiasis may occur, and tongue changes can disappear in 2-3 weeks after normalization of the internal organ function. And treatment. Look, please, clinical page. It is false black tongue. Sorry. And treatment children with a black hairy tongue should be examined for the detection of contaminant somatic illnesses. And it is advisable to apply local fungicide and keratolytic drugs, so doing different applications. Next one, folded tongue, and it is considered as a variant of the norm. And clinical, it is macroglacia with normal structure of mucous membrane and papilla, and folds are located predominantly symmetrical, then longitudinal and transverse direction. So food may accumulate there and cause odors, and halitosis requires carefully hygiene measures. So next one. Thank you guys for your attention. I wait for your conspects, and I want to speak about diseases of the blood and malignant neoplasms of lymphoid, hematopoietic and related tissues. So look please to classification and groups of hemorrhagic diathesis that caused by blood clotting disorder, then due to thrombocytopenias disorder and caused by damage to the vascular wall. Features of the dental status in coagulopathies. It is about bracing, prolonged lingering bleeding after minor damage, and intradermal hemorrhages are large hematomas with minor injuries. Bleeding from the interdental papilla. It is difficult to remove teeth and stop the bleeding during the treatment, and high prevalence of caries, poor oral hygiene, and gingivitis. Thrombocytopenia and primary or secondary idiopathic thrombocytopenia purpura. Please look to this table. Next one, Burghoff's disease. It is a disease that characterized by a tendency to bleeding due to thrombocytopenia and with normal or increased number of major karyocytes in the red bone marrow. And clinical pages of petechia of the skin and tourniquet symptom. Then features of the clinic and dental status. The first signs of bleeding appears in children at the age of 5 to 6 years. Hemorrhage is the skin for no apparent reason at the slightest injury or spontaneously. Then positive symptom on tourniquet. There may be internal bleeding, air bleeding, and bloody tears and sweat. Osler-Rand-Weber disease. It is multiple telangiectasis of characteristic areas. So it is lips, oral cavity, nose, ears, and recurring spontaneous bleeding, nose or pulmonary. Then the vessels of any area are affected, including the lungs, brain, and its membranes, and papilla hemorrhagic rash, sometimes blistered. And different syndromes. Features of the clinical and dental status with vasopathy. It is triad. It is skin rash, joint damage, abdominal syndrome. Clinical pages. Then the iron deficiency anemia. The tongue is smooth, polished due to atrophy on the filiform papilla, and perversion, taste sensitivity, paresthesia, and sometimes the appearance of fold on the back of the tongue. And features of the dental status with leukemia, acute leukemia and chronic. With acute leukemia, it is necrotic processes with the formation of extensive painful ulcers, and the tongue is edematous, covered with a brown blood. At the beginning of the development of ulcerative necrotic changes in oral cavity, then in the presence of the traumatic factor, profuse bleeding is possible. And for chronic leukemia, hyperplasia of the lymphoid apparatus of the tongue in the terminal stage of the disease, and candidiasis can be observed. Then, as a result, leukemic infiltration of the gum and destruction of alveolar bone and tooth mobility. Dental care, it is prevention of chemotherapy, stomatitis, and oral microflora control, analgesia, and correction of hypersalivation and xerostomia. Clinical pictures, sorry. Then changes in oral mucosa in diseases of gastrointestinal tract, so hypertrophy of filiform papilla, paresthesia in the area of the root and tip of the tongue, swelling of the lips, catarrhal and hypertrophic gingivitis, plaque on the tongue, swelling of the tongue, and candidosis. Gastritis and changes in the oral cavity, folded tongue, cheilitis, catarrhal gingivitis, and desquamative glossitis. Changes in the oral cavity with enterocolitis. It is swelling of the tongue and taste disturbances. Then with severe intoxication and dysbacteriosis and hyperplasia of filiform papilla and their staining in brown and even black, and chronic recurrent phthosis stomatitis. Changes in the oral cavity with peptic ulcer, increased temperature and tactile sensitivity, dry mouth, a yellow-brown coating of the tongue, dyshyperemia and swelling of the tongue, hypertrophy of the, of the candida and filiform papilla of the tongue, catarrhal stomatitis and gingivitis and angular cheilitis. Then changes in the oral cavity is in diseases of the liver and biliary tract. It is periodontitis, dry mouth, hyperesthesia of hard tissues, blister, bite taste and liver odor from the mouth. Then swelling of the tongue, atrophy of the filiform papilla of the tongue, and bleeding gums, as well as various form of gingivitis. And clinical pictures. First pictures, it is white tongue. Then next one, it is a different type of cheilitis, and third type you can see from the teeth that tongue have big sizes, and that we can see teeth on this tongue. And drying tongue and desquamative of epithelium. Then changes in the oral cavity in diseases of the endocrine system, hyperthyroidism or myxedema. The tongue is enlarged, swollen, dense. There are folds on its dorsal surface and papillary hyperplasia. On the lateral surfaces of the tongue, teeth prints. And thyrotoxicosis, it is burning of the tongue, decreased taste sensitivity, flattening of filiform papilla, and the appearance of foci of desquamation of epithelium. And changes in oral cavity in diabetes, so hypersalivation and dry mouth. Then pseudoperotitis, enlargement of the submandibular and parotid salivary glands. Then a phenomenon of dyskeratosis, catarrhal gingivitis and stomatitis can be, chronic generalized periodontitis, fungal lesions of the mucous membrane, and on the orthopentamogram, a mixed type of destruction of bone tissue is determined with a predominance of the vertical type of destruction over the horizontal and crater-shaped and funnel-shaped bone pockets. Changes in the mouse with kidney disease, chronic adrenal cortex insufficiency, the appearance of age spot of the tongue, gums, cheeks, and plate and hyperfunction of the adrenal cortex. It is glossitis with symptoms of hyperkeratosis of the dorsal surfaces of the tongue. Ulcerative processes can be and candidosis. And clinical pages, it is previous slide. Then scream proecological zones of internal organs in the language, in the tongue. Yes. And thanks guys for your attention. Wait for your synapses. Have a good day.